of E. coli and Klebsiella pneumonia is so resistant that more than 50%. So it's indicated as the high prevalence of resistant enterobacteria in our setting. And second is gabapentin resistant enterobacteria. So it's currently detect around 5 to 10%, although the percentage is low, but it's still concerned because the gabapentin are considered as the last line antibiotic that we use in our hospital. For the Staph aureus, MRSA, we can see it's resistant to methicillin. It's about more than 50%. So it's also in a high level of resistance for Staph aureus infection. For Staph aureus that are resistant to erythromycin and clindamycin is more than 70%. And for the Pseudomonas aeruginosa is approximately around 20% resistant. And for Acinetobacter is close to around 50% resistant. So it's also a concern of AMR. Moving to the next slide is talk about the improvement for AMR surveillance. In this slide, we want to show that we have done that we also update our AST guideline based on CLSI M100 as 36 in 2026. And we also have done on training our update AST guideline and staff competency. And one more thing, we also refresh training on SOP and new SOP every Friday morning. For our limitation here, we want to mention a few points that our LS is unable to extract a report for AMR surveillance system. So it's kind of challenging for our work for AMR. And one thing is lack of regular equipment maintenance and calibration, like incubator or refrigerator. For EQA, we also limit in supportive EQA activity also. And for the supply, we also lack of supply like some consumable, media, or reagent for our work in microbiology lab. For last slide is about the recommendation. For recommendation in microbiology lab, we report the monthly AMR data result to IPC team to avoid the AMR pathogen outbreak in our hospital. And AMR data results also should share with the AMC team to reduce the inappropriately antibiotic use also. And last but not least, with AMR data, for AMR data result, we should be used for clinical practice guideline in a hospital too. So my presentation come to the end, and thank you everyone for paying attention for my presentation. Yes.
Okay, thank you so much, Moniniet, for your presentation regarding to the AMR implementation in the Khmer Soviet Hospital. Yeah, everybody had a comment or a question or suggestion. So please go ahead.
Hello, everyone. Can I ask a question? That was a brilliant presentation.
Yes,
And I think really good, and really congratulations to the team for that effort to increase the number of samples going through the lab. It's really, really impressive. And I think, you know, the data is looking really, really interesting. My suggestion is, coming to your point, I think really important about infection control and guideline development. It would be fantastic if you could split the data somehow by community and hospital-acquired infections to get an understanding of, you know, I mean, where those important pathogens and where that resistance is. I'm suspecting a lot of this is in hospital-acquired infections, but it would be really interesting to see that. Now you've got such a lovely amount of data, you know, to see 300 E. coli bacteremias a year in a Cambodian hospital is, I mean, it's scary. That's a lot, but it's compared to the data that we were seeing a few years ago, it's looking really good. So that's something to look to, I think, if you can. Over.
Thank you.
So, do you have other comment from Professor Paul?
Not specifically. I mean, I think obviously there's a lot to get into in this data. Again, as I said, I think at the last meeting I was at, I would stop presenting the resistance to drugs where you know where there's intrinsic resistance. So I think it would be really helpful if we stopped highlighting the intrinsic resistance of Burkholderia pseudomallei to colistin, to ciprofloxacin, and the aminoglycosides, because it's distracting. I think what was really important to see there is you're not seeing any cotrimoxazole resistance. And that's the result I would highlight for the Burkholderia pseudomallei, because that's really important, so we can be happy with our consolidation treatment. And I think also well done for not finding any ceftriaxone resistance in pneumococcus. I think it's very easy to get that one wrong, and I'm sure that's the right result. So it's great. And I would offer, if there was any interest in having pneumococci serotyped, we still offer a serotyping service up here at AHC, and we would be delighted to get a better sense of the serotype distribution now that we're 10 years PCV13 introduction. Thank you again.
Thank you so much, Paul, for your comment. And for my side, I'm really appreciate to the Khmer Soviet Hospital. I would like to inform the team that the Khmer Soviet Hospital just joined us as AMR surveillance site 2024, and we consider as officially the 2025. So after the COVID-19 outbreak, that the Khmer Soviet that the present already, Khmer Soviet Hospital is the front line, the hospital that take care a lot of the COVID-19 patient in there. So now we saw that the 2 year, this 2 year later, they collect a lot of the sample, and we can have the show us regarding to the AMR surveillance that we conduct so far. So very appreciated. And one more thing, that we still had a contamination rate is a bit high. So I think that the microbiology team should do the ward round to the ward that had a high contamination, so you can show them like regarding to mentoring or coaching to our staff who collect the sample, avoid that the contamination rate like this. Yeah. So
Yes,
I
thank you,
think that
Nicole.
yeah. So thanks to all the team from the Khmer Soviet Hospital. Yeah.
Dr. Sidon, there was I don't know if you see it, but there was a question for Dr. Pravin. Praveen, I'm not sure if you have access to microphone. Actually, Dr. Praveen was asking the question. First, he congratulates you for your your wonderful presentation. And he would like to understand what are the challenges in data extraction from LIMS and which LIMS you were using.
We are using Urea LIS, so we cannot extract the information of patient to access the AMR surveillance system. It's also a bit challenging for us too.
Thank you.
Yeah. So the Praveen asked this question and respond already, right? And who else will? Oh, Praveen in bus. So
That's but he could listen to us, so I guess he heard the answer.
Yeah. So one more thing regarding to the limb. Professor Paul, do you have talking with the Khmer Soviet or not yet?
Not yet, Dr. Sidon, but this does seem like an ideal opportunity to start the discussion. We would be very happy to talk about.
I think that we can go together if you allocate time when
Yes.
you can come and
Yes, let me discuss that with
we
you.
can go together. And we
Okay.
have the appointment from the us, and I will send the letter to my Soviet hospital if you have time to go together.
Yeah, I'll
Let consult with the my Soviet hospital first.
Perfect.
Yeah. Okay, if I don't have another comment or suggestions, thank you so much for Khmer Soviet Hospital that present to us regarding to the MR progress in the hospital. Yeah, thank you so much. And may I move to the next presentation from the part, Mr. Kian Palm. So please go ahead.
Thank you, Dr. Sidon. Let me know if you can see my screen now.
Yeah, I saw it.
Okay, thank you. So, so my presentation today, it won't go into too much detail, as I know Dr. Sidon has told me that the TWG meeting today needs to be wrapped up in an hour. So I'll be prompt in my delivery. But the presentation will be on PATH's past and ongoing effort to promote AMR data quality improvement and data use in our projects around the world, with the focus in Vietnam, as well as some preliminary findings of the OH4CAM project related to AMR. So, brief introduction to PATH. We are global public health NGO based in Seattle, Washington, the United States, with an overall mission to advance health equity through innovation and partnerships. And we are based in multiple regions and have country offices around the world, as you can see here on the map. Specific to our Southeast Asia hub, the hub office is based in, again, Hanoi, Vietnam, and it covers programs in 4 different countries of Vietnam, Laos, Cambodia, and Indonesia. And our primary areas of work include infectious diseases, epidemic preparedness and response and malaria, primary healthcare, and vaccine and immunization. So moving to our strategy to combat AMR, which PATH has maintained a very consistent AMR strategy for over 10 years now. And this slide shows the 4 key principles That is to support stronger surveillance systems in human, animal health, and now environment health sectors, strengthening health systems and lab infrastructure, supporting the global exchange of information, and enhancing data reporting, monitoring, and evaluation. And next, with One Health rising into prominence and with the interconnected nature of AMR across the different sectors, PATH has applied a One Health approach to AMR information systems. And this graphic shows the 7 key principles that we apply in multiple different programs, and especially the AMR support in Vietnam. Number 1 is standardization of data for animal, antibiotic, bacteria, specimen type, and patient codes according to WHO and HUNET standards. Number 2, to develop a module to interpret anti-susceptibility testing results according to CLSI and ERCA's latest guidelines. Number 3, working with government counterparts across different ministries to develop standards for reporting national data. Then to co-construct an online information portal to receive AMR data and be ready to connect to other systems. Number 5, we provide assistance in examining and validating data for quality improvement and control before importing into the national system. Number 6, build a statistical analysis dashboard for the needs of the ministries, labs, and referencing international standards and reportings. And finally, working with preferably in-country software development unit to ensure system sustainability and readiness to connect towards One Health. So this next section will detail some of our in-country work on AMR. PATH has a very broad AMR portfolio that we have been able to implement in multiple different countries with focus in Southeast Asia and Africa. And the 3 key projects that we have done in AMR work in are the Fleming Fund project, the Infectious Disease Detection and Surveillance, or IDDS, and the US CDC Global Health Security Partnership. And all of these work cover multiple spectrum of AMR surveillance strengthening, as you can see. So first, I want to talk about our work in improving AMR data quality in Vietnam, which PATH have been heavily involved in since before the start of the national AMR surveillance system in Vietnam. And for AMR data quality improvements specifically, PATH applies a TOT approach, where we provide mentoring for the AMR focal staff at the National Reference Laboratories for improving their data review and curation capability. After this, we facilitate technical assistant trips with these NRL focal point to Sentinel sites to assess AMR data quality and management at these facilities, and also assist in holding quarterly technical meeting to provide feedback on data entry quality. And finally, PATH was very honored to develop the AMR surveillance bulletin. So the first AMR surveillance bulletin in country. And this slide shows some of our, I want to say, highlights or principles for standardizing the data input into the national portal. So some background information was that when the Vietnam first started its AMR national surveillance back in 2018, the hospitals would submit report in Excel files with non-standardized codes. So they have different coding nomenclature for organism, for antibiotic, etc. And realizing that this would make national surveillance an impossibility, We supported data standardization and creating standardized code lists in the national portal that are aligned with HUNET and CLSI standards, but also realizing the need for hospital continued use of the standardized list. We further supported translation of standard coding and terminology into Vietnamese and embed the Vietnamese translation into the national portal as well. Next, we supported the training and deployment of BigLink, which is a sub-program of HUNET that can map all of the hospital AMR files into HUNET compatible format that the hospitals can use to work within HUNET, work on that data within HUNET, and also upload into the national portal. And finally, after we recruited the local IT vendor for the portal development, we work with them to implement an automated data validation function that will be triggered automatically whenever the hospital would upload their data file. And this function would check for things such as intrinsic resistance, logical antibiotic panel or organism selection, and other checks, and can flag or outright reject erroneous files that the hospitals would need to rework or delete before they re-enter into the national database. So some key results of our work in Vietnam was that we were able to help improve monitoring and control of AMR for both human and animal health sectors, and the improved utilization of standardized data formats for reporting. PATH helped to, we utilized the same approach that we applied to develop the national AMR portal in the human health sector, and resulted in the expedited development of the AMR reporting portal for the animal health sector. And you can see the screenshot dashboards of the two portals right below. And both of these portals incorporate global standards by WHO and FAO, as well as some specific government requests, such as specific filters, trend analysis, site ranking, to both serve international reporting and domestic ownership purpose. And this slide just briefly shows our application, our reasoning for application of HUNET, which we help to facilitate adoption in all the facilities in Vietnam. As many of you may know, HUNET is a dedicated software for microbiology lab data management and AMR analysis used by labs around the world. They use standardized organism codes, antibiotic codes, and interpreted breakpoint by the latest CLSI or ERCAS standards. And HUNET also directly supports WHO GLASS reporting. The software has modules for lab configuration, data entry, and analysis, reporting, and encryption. And as I've alluded to before, the companion tool BigLink helps HUNET convert and standardize text files, Excel file, and LIMS export into HUNET format that we use for submission into the National AMR portal. HUNET is also free and open, and it has continuous support from a large online forum. And Dr. John Stilling, who heads the initiative, conducts regular annual training. For Vietnam, HUNET has served as a practical standardization layer to help bridge between diverse hospital files and national AMR reporting as a common microbiology data language. And within Vietnam, we would have hospitals using different data sources, and that brings up the need for one national structure. And we then facilitate the process in which hospitals will be trained to map their files via BigLink into the HUNET standard format that they can submit to the national AMR database. And HUNET is useful for providing a standardized structure, breakpoint alignment, conversion of existing data, as well as serving analysis reporting purpose. Moving into another example, so in our work in Tanzania, for promoting connected diagnostics, some background information is that in Tanzania, in the past, hospital labs were not capturing AMR surveillance data due to the limited surveillance functionality of their limbs. So PATH, via the IDDS project, worked with the National Public Health Lab to perform standardized microbiology, culture, and AST in 4 designated hospitals. We also supported integration of LIMS data from the sites into WhoNet format and created interoperability linkage between LabNet, which is the Tanzania program, and the National Electronic Integrated Disease Surveillance and Response System. And as a result of this work, of the four participating hospitals doubled their testing capacity within a year. All the diverse members of the hospitals meet regularly for clinical sensitization, mentorship, and support. And these sites continue to hold quarterly meetings to review the AMR data quality. Moving into another example in Senegal, where PATH, through different projects, have been able to support enhancement of the full AMR data process. So in the Global Health Security Partnership, we support enhancing AMR testing capacity of the micro labs in the surveillance network. Through Fleming Fund project, PATH provided support for AMR data collection, analysis, and reporting. And with IDDS, PATH helped to improve AMR reporting timeliness and completeness, develop national SOPs for surveillance activity, and help improve diagnostic practices. So that is a screenshot of some of our notable AMR work in Vietnam and as well as in Tanzania and Senegal. I want to spend the last couple of minutes to talk about some preliminary findings of the One Health for Cambodia project's inception phase. So as most of you here may know, but for the German colleagues who have just joined, these 2 graphics detail the AMR testing flow, as well as the AMR data flow in Cambodia, specific to the AMR Sentinel surveillance system in the human health sector. And I won't go into too much detail here, but I will share the slides later on for whoever needs it. In Cambodia, as we see, have established some key multi-sectoral architecture in place, most notably through the endorsement of the latest update of the multi-sectoral action plan for AMR, the continuing activity of the AMR technical working group, starting with the multi-sectoral TWG, as well as the drafting of the M&E framework for the MSAP. And the 3 boxes at the bottom details the current status of the AMR surveillance or activities within the human health, which is the most developed sector in the country for AMR, animal health, where we see a lot of project-based activities, and environment health, where we are still seeing very limited microbiology in place. So at the start of the OH for Cam project, the PATH team, with the help of the government counterparts as well as other stakeholders, went out to do a series of engagements and review, and just to see like what has changed since our original feasibility study in 2023. From this 5-6 months period, we see that AMR still receives recognition as a top One Health priority in the country through the satellite event speeches, discussion, as well as various stakeholder engagements that PATH conducted. We also recognize a lot of the achievements in AMR since the feasibility study, such as the expansion of the Sentinel network, the MSAP update, and other cross-sectoral research, and overall increase in sample testing for the Sentinel network. Nonetheless, we want to flag data action gap, as Sentinel surveillance is not yet informing clinical guidelines, IPC protocols, or general stewardship. There's still limited communication between clinicians and microbiologists for various different reasons. We also identified some key early support areas, such as the update to the latest CLSI guidelines for all of the Sentinel sites and data validation for AMR reports. And finally, we recognize the willingness from the key ministry focal points to start discussion for information sharing, moving towards a later goal of integrated surveillance for AMR. In this slide, I won't go into details, but it shows our findings related to laboratories and diagnostic that is very much tied to AMR and microbiology. And finally, just a refresher for those who we have engaged with or with people who are new to OH4Chem. The project is a 5-year engagement funded by KfW to establish a sustainable One Health system in Cambodia. And here, OH4Chem have selected AMR as a use case. And in the original feasibility study, we have proposed a large majority of activities centering around or having AMR-related components. And these AMR activities span through multiple categories, as you can see here, from surveillance strengthening, AMC surveillance, animal health routine support, environment health surveillance startup, lab strengthening, stewardship and general awareness raising, and facilitating increase in the in-country AMR knowledge base. And after this 5-year period, we really hope to achieve key outputs related to AMR strengthening through OH4Chem, such as standardized quality assured AMR Sentinel surveillance, functional clinician and microbiologist feedback loop, routine AMR surveillance in the animal health sector, functional AMR capacity in the environment side, operational stewardship and IPC model at these targeted provinces of Battambang, Kampong Cham, and Kampot, assisting the operationalization of the MSAP and its M&E framework, and coordinating with partner contributions to reduce duplication and increase synergy. And here, the final slide, it just shows that PATH, we're really hoping to garner our existing network and work to help to facilitate future opportunities for a regional exchange of knowledge or possibly cooperation in the AMR field between either Vietnam, where we have a lot of work in, Cambodia, where we're starting work with OH4Chem and other technical assistance work, as well as our other partnership in countries such as Malaysia or Indonesia. So this is the end of my presentation. I want to thank you all for listening, and my apologies for going a little bit over time, but I do welcome all questions, or if you have questions that we do not have time for, you can email our PATH contacts listed here in the presentation. Thank you.
Thank you so much, Ken, for your presentation. I think they're very useful for us also regarding to the what we will do next. And we had the inception report regarding to your presentation. So I will collect from the OKI or TZW or FRI can understand regarding to this as well. Yeah, and If you have some comment or question to Mr. Kian, so please go ahead. Our team also. So I think that we will work together. So from today, like 5 years more, regarding to this. So especially the 3 provinces. Now we have representative from Battambang and the Kampong Cham, but don't have the Kampot province yet. So I think that we they know that the project will in the inception progress. So we will work more regarding to this. And OKI that had a representative here, I guess. So he will bring us and had us how to improve all the AMR surveillance that we conducted so far since 2018. So I think that do you have something to add? Jim, please.
Yeah, I just wanted to say on behalf of the PATH team to thank Kian, but really to say that obviously, PATH brings some expertise, but there's an amazing amount of work that's already been done in the country. A lot of partners doing fantastic work. We are here to contribute our part. We're going to learn as much as we can probably contribute. So I just want to make that clear that we're really excited to work with everybody and build off the great work being done by many, many partners that have been working on this for many, many years. So we look forward to a great collaboration, and hopefully we can all benefit from bringing in the 3 German institutes that have joined the project as well. Thank you.
Yeah, of course, Jim, that we need the technical support from our colleague from the OKI, something that we would like to our system or our data very useful for the clinician, for the IPC or for the AMS, because we find out that we still had the limited for our data we had in the system, but regarding to analyzing it or something else, so we did not feedback to the clinician for the confirmed diagnosis or the patient. This is a very useful, as recommended by GE. Also, they encourage the microbiologists or data from the surveillance to improve the quality of treatment in their hospital better than the sharing to the global antimicrobial resistant surveillance at the AQ. So very strong recommended too. So this we need to improve our team as well as the implementation of the SOP for that we conducted many years already. Yeah, and one more thing regarding the COOLNet. So let's see together how we can connect with the AMR surveillance system and the CAMBIS system. Can we have another like the flow or method to more easy analyze for us? It's better than. Let's see together for another collaboration and working together. Francis, you have something, yeah? No?
No, just wanted to say thanks for the nice presentation.
Okay, good, yeah. Thank you for also apologize for today. I think that we would like to our team here, CDC, today we will go to join the funeral of my director, the father that passed away, and so we need to go now after this. So we are waiting